The need for team working to ensure high quality IBD care is well recognised. However, with new drug treatments available, novel surgical techniques, and a better understanding of both the psychological impact of IBD and the role of diet, it's never been more important. I'm John Paul Seenan. I'm a consultant gastroenterologist at the Queen Elizabeth University in Glasgow, and I'm where I lead the IBD team. As part of the Digest This series, we've been asked to run a simulated MDT. So I'm joined by some of my nursing, dietetic and surgical colleagues to discuss how we would manage a couple of fairly typical but entirely fictional IBD patients. I'd like to introduce my colleagues. I've got Jen Clow from dietetics, Susan Laird, who's our lead IBD nurse, and Paul Witherspoon, who's a consultant colorectal surgeon. So Jen, I think the first case is yours.
Yep, I've got a 45-year-old male with terminal ileal Crohn's that I've seen in clinic. He was diagnosed in 2019. He was initially referred to us with stricturing, for stricturing advice. He had some obstructive symptoms. We've gone through some first line information, some of the texture modification diet, and a wee bit of low residue information. However, he's still complaining of the obstructive symptoms, and he's got intermittent pain and vomiting. I note his fecal cal is high and his recent MRI is now back and it shows some acute on chronic inflammation. I was just wondering if we should be thinking about stepping up his nutritional therapy here to help kind of manage that inflammation. I can aim for exclusive enteral nutrition as a kind of gold standard for this. It's used for managing active Crohn's disease, and it has got really good evidence of response rates of up to 70 or 80%, which is similar to that of steroids, and it's got the added bonus of showing a bit more mucosal healing. So is there anything else that we should be thinking about in terms of surgical or medical therapies for this chap?
I mean, there's certainly medical options we could consider, but he's a smoker. And I think the first thing that we need to suggest is that he stops smoking. We know that makes Crohn's more difficult to treat, and we also know that it increases the risk of complications and the rate of surgery. So if he's agreeable, I think we should be encouraging him to engage with the smoking cessation service to begin with. In terms of medical options, it sounds like he's got active disease radiologically, and he's only tried an anti-TNF, so there's various other drug options that we could consider. We've got ustekinumab, which is an effective treatment in Crohn's disease. We'll soon have biosimilar ustekinumab, which will make it more cost effective. Other alternatives, so we could consider risankizumab. So that's obviously more expensive, it's a newer drug than ustekinumab, but the head-to-head data from the sequence trial suggests that it's more effective when it was compared to ustekinumab and anti-TNF failures like this. Vedolizumab is an option, but a lot of the network meta-analyses where they try and kind of indirectly compare the different drugs suggest it's probably not as effective as ustekinumab or risankizumab, particularly in patients who have failed an anti-TNF. In terms of other options, so we use a lot of small molecules now, so drugs like upadacitinib, or we've got upadacitinib that we can use in Crohn's disease. However, we tend to use that in younger patients, particularly males, because we try and avoid it in women who are hoping to start a family. We are advised to avoid it in patients who have got risk factors for cancer, cardiovascular disease, or venous thromboembolism. Anyone who's over the age of 65, but also current and previous smokers. So again, that's where the smoking, I suppose, would be relevant here. It's probably something that we wouldn't want to consider unless there were no other alternatives available. So he's got a number of medical options. We could discuss these things with him. I suppose the other thing that I would think about is that we've got data from the LYRIC trial recently suggesting that terminal ileal resection in patients with isolated inflammatory ileal disease should probably be getting used earlier. So again, that's maybe something that we should be thinking about discussing with them. What do you think, Paul?
Yeah, you're right. I mean, the LYRIC trial demonstrated that laparoscopic vesical resection for kind of this kind of limited disease is at least equivalent to infliximab. And the interesting thing about that is about a third of the patients who were randomised to infliximab ended up getting an operation anyway. So yeah, it's definitely an option. It certainly challenged conventional wisdom about timing of surgery, and it's kind of reflected in the recent guidelines. I mean, this patient's a primary non-responder to anti-TNF, so then that's another reason to have a balanced discussion with them about surgical as well as medical options. I completely agree with you regards starting enteral nutrition. You know, if he does choose surgical therapy, then in addition to reducing the inflammation, it's also going to optimise his nutrition, which I'm going to be interested in, and it might help with any pre-stenotic dilatation that's developed since his MRI. Whatever he decides, I completely agree, he really needs to stop smoking. It does increase the risk of post-operative complications in general, and smokers have a higher risk of recurrent Crohn's post-operatively, and it usually happens earlier and it's usually more severe. So we need to kind of counsel him to stop and support him to stop smoking. And he has to stop completely, not just cut down, because even passive smoking can contribute to that. He's otherwise a fit guy, so you know he should be okay with surgical intervention, but there is small risk of serious complications, so we still need to counsel him carefully about those things as well as medical therapy. So I probably would have thought he'd benefit from a combined consultation at our shared clinic to discuss both his surgical and medical options.
And you know him quite well, Susan, don't you? What do you think?
Yeah, we've come across him a few times in our service simply because I think he struggled mentally with his diagnosis and his symptoms at the start when he was diagnosed. He does have a history of anxiety and depression, and certainly we did raise to stop smoking at the time of diagnosis, but because of his mental health he wasn't really interested, but I think he might be open to that now, so that's something we can certainly rediscuss with him and refer him to the smoking cessation service. There has been an issue with non-adherence with medications in the past, maybe what contributed to the fact that he has not had a great response with TNF. So I think he would definitely benefit from being seen at the combined clinic to have these options put on the table, because it might be somebody that might think that a surgical option is more appealing than being taking more medications long term. He will obviously need something going forward in the future, but I think just to allow to have that break might be something he would benefit from, and certainly we can look at his mental health again, and if we need to tap him into psychological services, if it's linked with his IBD and things, we can certainly look at that going forward, but I think definitely would benefit from being seen at the combined clinic.
Okay, sounds good.
Great, okay, so just to summarise then, if I arrange EEN for him, I'll get him started straight away, and if we can aim for steroid-free remission for this chap, then that's all the better, especially for considering surgery down the line, and if we can get him arranged to come up to the combined clinic with you guys.
Yeah, sounds good.
We'll do that.
Yeah.
Good. Excellent.
So this is a 35-year-old lady that's contacted IBD Advice Line with worsening symptoms. She's got a diagnosis of ulcerative colitis. She's phoned up as she's been experiencing kind of bloody diarrhoea 5 times a day, no nocturnal stooling, fecal urgency but no incontinence, slight abdominal discomfort prior to defecation but no abdominal pain. She's just generally feeling kind of a bit unwell, feeling fatigued, and reports a bit of weight loss over the last 4 weeks. I know that she's had a most recent colonoscopy that does show a pan UC moderately active male score 2. She's currently on 2 weekly vedolizumab injections. She's previously had infliximab but lost response to that despite having good therapeutic drug levels. On discussion, we spoke about potentially she might be looking for a change in treatment because she does have active disease despite being on optimal medical therapy, and I did mention the fact that surgery might be an option for her, but she'd mentioned that she's actually planning on getting married in the near future and hoping to start a family. She does have psoriasis and is under dermatology as well, so I thought that might limit the medical options for her, or might push us towards certain medicines. But it was just to see what your thoughts were on this lady today and see what you think, really.
Yeah, I mean, I think she's got a few medical options, but there's certainly things to consider. I mean, we could try, in terms of biologics, we could try ustekinumab or mirikizumab, but if she's thinking about having a family in the near future, there's more data on ustekinumab suggesting that you can continue it throughout pregnancy, particularly from the piano registry data. if she was happy to do that, obviously that would be something that we would discuss with her in detail. But we'll increasingly advise that, obviously, because we think that the risks of a severe flare and the impact that that's going to have on a pregnancy will outweigh the risks of the drug itself. So that may be worth factoring into any discussions that we have with her. The other thing about ustekinumab, I suppose, is it is a good option for psoriasis, unlike vedolizumab. It's a drug that dermatology use for that, albeit they use smaller doses than we do. So I think, again, that's something to consider and to discuss with her, because 50% of our patients or thereabouts will have an extraintestinal manifestation or another inflammatory condition, and we know that the quality of life is poorer in this group of patients, and partly that's perhaps because we don't get the dual benefit from the drugs that we choose. So I think we need to factor that into the decision making. In terms of other options, I mean, we've got a number of small molecules now. We've got JAK inhibitors, we've got S1P receptor modulators. It's not an absolute contraindication, but we don't consider these drugs to be safe in pregnancy. So, I would err away from offering those to a patient who's thinking about that maybe in the next 5 years or so. That being said, we know particularly with the JAK inhibitors, they work quickly, so patients see a response, often within a few days, which will sometimes mean that we can avoid giving them steroids. And the other side of that coin is that they're out your system pretty quickly. So if she did want to go down that route, we would obviously advise using effective contraception, but it would only be for 4 weeks after they stop the drug that you'd have to continue doing that, and then beyond that, she can start thinking again about family planning. So there's a few things from a medical perspective to consider. But I mean, you mentioned as well, you've talked to her about surgery being an option, and I think she has got a number of medical options, but she's heading towards her third line just now, and by the time you get to that point, I think we've got to be honest with her and say that the likelihood of her getting a sustained response is less than it was before she started on this journey with the advanced therapies, possibly only about 30%. So I think in order for her to make an informed decision, we need to include a discussion about surgery. I don't know what you think, Paul.
Yeah, I'd completely agree. Although she has other medical options, it's still much more likely that she's going to end up needing surgery at some point, given her clinical course. And we know that most patients who end up with surgery have a good quality of life, and often they say they wish they'd had an operation sooner, and she might be in that situation. I'm also a bit anxious about multiple attempts at medical management, because we know it can adversely affect the patient's condition, and it can impact post-operative outcomes. I see that she's losing weight, so I guess that's something we might need to address, but I'd be interested in your view on that and any kind of nutritional things. We definitely want to assess her iron status and correct that preoperatively. In terms of our kind of family, we know any pelvic surgery can affect fertility, and it's difficult to estimate that. But for pouch surgery, rates as high as 48% have been reported. I mean, having said that, many patients have restorative proctocolectomy and go on to have successful families. We've got several patients who've had children. But I think we'd still probably be recommending a subtotal colectomy in the first instance, and suggesting that she defers any decision on further surgery until her family is complete. I don't know whether she's got any rectal sparing. It might be an option for an ileorectal if she's got sparing, but otherwise we'd say subtotal and have an endileostomy with a view to probably a modified 2-stage or perhaps a 3-stage restorative proctocolectomy at some point in the future. Her psoriasis is an interesting one. It's not a barrier to surgery, but from a surgical point of view, we need to think carefully about that. Hopefully, she doesn't have too many plaques on her abdomen. We might be able to plan our laparoscopic incisions around the plaques. We certainly would want to avoid cutting through them because she'll be at an increased risk of wound complications. And we know the stress of surgery, particularly if she had a complication, can cause a flare of psoriasis. Right. So I suspect we'd probably want to work closely with her dermatologist if she chose surgery. Again, she's young and fit, so she'll be fine if she chose surgery, but we still need to discuss, the risks and potential complications, because some of those are small but potentially serious. So she's probably someone who would benefit from being seen at our combined clinic. I don't know if there's anything you've got to offer.
Yeah, absolutely. We don't actually have as much evidence for dietary therapy in UC, although I do believe that there are studies coming, which is exciting. But certainly for this patient, we can absolutely see her and assess her in terms of her nutritional intake and provide some nutrition support advice and minimise further weight decline. We can also look at her diet in terms of nutritional adequacy. You mentioned about her iron levels. That's something certainly that we can look at and review. We can also discuss some symptom relief for her, looking at some of her dietary triggers and provide some support for this. There is advice, the advice that we give is anecdotal. As I said, there isn't a huge amount of evidence, but certainly if we can help her in terms of support her, especially if she's getting married, then that's something that we're happy to do. Obviously, it's not the case for this patient, but there is often some functional overlay with our IBD patients, both in UC and in Crohn's, when there is an active disease, and it's something to think about down the line for our patients. We often can provide some beneficial advice in terms of our IBS information, and using a kind of step-up approach, using lower FODMAP foods can also be something to think about in the future for these types of patients.
Okay.
Okay, that's fine. So I'll send her out information on the ustekinumab and the JAK inhibitors, and we can have the chat about that again. I'll let her know that she'll have contact from the dietetic team and that she'll get an appointment at the combined clinic going forward.
Yep, no, that sounds good. I mean, if she's struggling in the interim, we can consider a course of steroids, but we'll arrange an appointment for the combined clinic in the near future, and hopefully we can come up with a plan for her.
That's great, thank you.
Okay, thanks guys. And all that's left for me to say is to thank you, Paul, Jen and Susan, and thank you for joining us for Digest This.